Ameloblastoma is a benign odontogenic tumor. It is also called as a adamantinoma or multilocular cyst. It is a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. Now there are various theories regarding the pathogenesis of ameloblastoma. The first one is that it arises from the cell rest of enamel organ, either cell rest of seres or cell rest of marlaces. Then second pathogenesis, that epithelium of the odontogenic cyst, particularly the dentigerous cyst. Then thirdly, disturbances of developing enamel organ. Then the basal cells of surface epithelium of the jaws and heterotropic epithelium in other parts of the body, especially the pituitary gland. Presently, it is thought that it is likely to result of alterations or mutations in the genetic material of cells that are embryologically pre-programmed for tooth development. Coming to the clinical features, it has a wide age range. Most of the cases have been reported in 20 to 60 years of age. There is no sex predilection, and most common site is the mandible molar ramus area. It starts in the cancellous bone and enlarges slowly and extends to buccal and lingual plate of bone. There is always a continuous sheet of paper thin bone covering the tumor. The lesion may be solid or cystic. Here in the photograph you can see the lingual expansion of the lingual alveolus. Now radiographic features. It shows a multilocular radiolucency, either honeycomb like or soap bubble like appearance. It may be a unilocular radiolucency also. Resorption of the roots of the teeth adjacent to tumors is common finding. There is expansion of the buccal and lingual cortical plates. And in many cases, unerupted tooth, mostly the mandibular third molar, is associated with the radiolucency. Now the ameloblastoma, it has a radiolucent appearance, except that in Desmoplastic Ameloblastoma, it has a mixed radiographic appearance, that is a radiolucent with the radio opacity due to the metaplasia within the dense fibrous septa. Now this is the multilocular appearance of the ameloblastoma in the posterior mandible. Now coming to the histological variants of ameloblastoma. There are 6 variants. There is follicular ameloblastoma, then plexiform ameloblastoma, acanthomatous ameloblastoma, granular cell type of ameloblastoma, basal cell ameloblastoma, and desmoplastic ameloblastoma. Out of this, follicular and plexiform are most common. Granular cell ameloblastoma is the most aggressive type of ameloblastoma. Basal cell ameloblastoma, it is a least common type of ameloblastoma. Now histology of this follicular ameloblastoma, it shows histologically, it shows the islands of epithelium which resemble enamel organ, and the connective tissue stroma is mature. So these islands, they are lined by the tall columnar or cuboidal cells which resemble the inner enamel epithelium. So the cells are when the cells are tall columnar, they show the reversal of polarity. And these islands, they show the centrally placed polygonal, polyhedral or angular cells which are similar to the stellate reticulum like tissue. And cyst formation is more commonly seen within the epithelial islands. Now here you can see the cells arranged in the form of the islands, which are lined by, these epithelial islands are lined by the tall columnar cells. Here you can appreciate the tall columnar cells with the nuclei showing reversal of polarity and centrally placed stellate reticulum like tissue, and cyst formation is common within the follicles. Now secondly, second type is the Plexiform Ameloblastoma. In this Plexiform Ameloblastoma, the cells are epithelial cells are arranged in the form of interconnecting strands or cords. Again, these are lined by the columnar or cuboidal cells and they enclose the stellate reticulum-like tissue. But the stellate reticulum-like tissue is scanty here in Plexiform Ameloblastoma, and cyst formation is by stromal degeneration rather than the cystic change within the epithelium. Now see, these are the cells arranged in the form of interconnecting strands. And these enclose this stellate reticulum-like tissue, which is scanty here as compared to follicular ameloblastoma. Now third type is the acanthomatous ameloblastoma. Here there is a squamous metaplasia of the stellate reticulum-like tissue within the central portion of the epithelial islands of follicular ameloblastoma, and this may show the keratin pearl formation. Now see, these are the epithelial islands, and this is the squamous metaplasia of the stellate reticulum-like tissue. Now here you can see the stellate reticulum-like tissue, but these are the squamous cells, and keratin pearl formation may be seen here. Now next type is the granular cell type of ameloblastoma. Here there is a marked transformation of cytoplasm of stellate reticulum-like cells. The cytoplasm is filled with the eosinophilic granules, and these granules are the lysosomal aggregates. Now see, this is the follicle, which is lined by the tall columnar cells, and these are the centrally placed cells where you can see the eosinophilic granules. Here the granules are clearly seen, and this is the nucleus. So eosinophilic granules, this is the most aggressive type of ameloblastoma. Now next is the basal cell ameloblastoma or basalite type of ameloblastoma. Here it resembles the basal cell carcinoma of the skin. So the nest of uniform basalite cells are running in the sheets. Peripheral cells, they are cuboidal rather than columnar, and there is no stellate reticulum like tissue in the central portion of the nest. Now see, it resembles the basal cell carcinoma of the skin. Now next is the Desmoplastic Ameloblastoma. This consists of thin strands or cords of odontogenic epithelium in a dense collagenous stroma. Here the stroma is dense. Epithelial component, it appears compressed here. And the central cells, they are scanty, and peripheral cells, they are flattened or cuboidal rather than tall columnar. See, this is the Desmoplastic Ameloblastoma. The epithelial islands, they appear compressed, and there is a dense collagenous stroma. Now treatment and prognosis. Radical or conservative excision is the preferred treatment. Curettage is less desirable as it is associated with the increased risk of recurrence, and long-term follow-up of the patient is necessary. This conventional ameloblastoma is infiltrative neoplasm and may kill the patient by progressive spread to involve vital structures. However, most of these tumors are not life-threatening, so prognosis is quite good, and rarely an ameloblastoma may show frank malignant behavior, but it is rarely seen.